David, are you relieved that we have federal funding through the rest of the fiscal year?
Oh, Todd, I am very much relieved. There's so many things in doubt these days that every once in a while you're just like, thank you for doing what your job is to do, which is pass a budget and keep the government running. Thank you, Congress.
So, from the perspective of the kidney community, what are some of the highlights in this funding package?
Well, I mean, Todd, it's a big one. It's $1.5 trillion. It's one of the biggest non-defense spending pieces we've had in some years, and it's a very big one on defense as well. So there's various things to break out. I guess where I have been most focused, and I'm not saying this is the only reason why we should, think we should talk about. There is humanitarian aid and military aid for Ukraine. But there was no COVID-19 relief funding, as you know, that came out. And it does cover all of the 12 appropriations bills that make up the federal government. So there doesn't have to be anything kind of stitched together between now and September 30th to keep everything running. But it is labor HHS is a the $213.6 billion appropriation, which is about a 7.7% increase across those two areas. And it does provide good, healthy funding for the National Institutes of Health. So that was it. But I was going to kind of get to the regulatory signals that it did send pretty soon. But if you want to add more to this, let's go ahead and talk. Do you want to talk more about the money?
Yeah, I mean, I think before we get to the regulatory signals, which I agree are really important, just to highlight maybe three things for our listeners. You had mentioned labor HHS. So just so people know, the way the appropriations process is supposed to work, again, fiscal year for the federal government's October 1st through September 30th. So this is funding us through the end of September. The bill's then organized around agencies, and those agencies are grouped together. So the Department of Labor and the Department of Health and Human Services are kind of funded together, if you will. It's interesting because even as I say it, it sounds like it's already an antiquated system, but it is the way to think about it. And then within the Department of Health and Human Services.
And education.
And education, I'm sorry. So it's labor, HHS, and education. That's correct. And so within the Department of Health and Human Services, you have the National Institutes of Health, you have the CDC, the FDA, the Health Resources and Services Administration. So you have a number of health-related agencies and research agencies. Of course, the Department of Veterans Affairs is a separately funded agency within the federal government, and it also received reasonable increases for the rest of this year. So that's sort of the first point. I think the second point is, in addition to the funding increase for NIH, which is sort of across the board, so including all the different institutes, even the National Institute for Diabetes, Digestive, and Kidney Diseases, there was some funding to create this new concept of a sort of DARPA-like structure at HHS called ARPA Health. And currently it's sort of connected to the NIH. So that I'd just be curious as to your reaction to that, and then I'll come to my third point.
Well, I mean, we're both, we've both been around Washington long enough to know when the original the ARP was created, which was DARPA and created for defense. That was a pretty interesting and has been a pretty interesting program that has produced a lot of results. A lot of results that a lot of people probably don't even know came out of the DARPA budget. But it's really designed to be a situation where the government says, okay, this is a really serious issue, as defense is, and now it's going into healthcare, and it's saying we're going to give those of you who are the experts in healthcare, we're going to give you a significant pot of money, and we're going to let you kind of have some freedom to use it as you see fit. And that means you get to do things like, okay, we have a really interesting possibility to make a difference in something that no one's ever dealt with on a particular disease state or a particular, let's say a procedure or something, but any type of thing. And it gives them the freedom to kind of say, okay, we're gonna take a real shot at this, and we're gonna go outside the boundaries a little bit. Would you I mean, maybe I'm just being too whimsical about how I describe it, but that's kind of how it's always been in my mind. It was kind of a little bit more of a free trade zone where a bit more could happen without it all having to be hammered out detail by Congress. Does that make sense?
Yeah, it does. And I think the nuance here, which we've talked about before, is that if it's placed within the National Institutes of Health, which seems to be the Biden administration's preference, and former NIH director Francis Collins is now at the White House, and one of his roles is to lead this advocacy effort. Then it's going to probably look very much like NIH. And I think a lot of the funding priorities will be similar to NIH's, which has already been stated by the administration in terms of, specifically the cancer moonshot, Alzheimer's, diabetes. The priorities are very much aligned with the NIH priorities. So I think that's the one nuance here to sort of to watch, because Congress kind of left that open in terms of the funding. Before we, just as we're talking about creativity in funding research activities, I should say the final point, the third one I wanted to make about the legislation is that the funding bill is that there was also a $5 million appropriation for Kidney Acts. So continuing to fund that in the Assistant Secretary of Health's office at HHS. So again, exciting development for our community.
That is exciting for the kidney community, and the leadership that you and others have brought to that whole issue, and bringing ASN and its resources to bear to really kind of help support that is really something very, that you should be commended for. I did want to say one thing and see what you think about this. Sometimes, some of us have been in our conversations a little nervous about the funding for ARPA-H being included in NIH. And I was just going to say, it's not because of any particular distrust of NIH. It is nothing. I mean, we are big fans of NIH. NIH is fantastic. The problem is sometimes my concern, and let's see what you think of this, is Congress can have a short-term memory. And people come and go on Capitol Hill all the time, and members of Congress last 2 years and sometimes, and that's it. And it doesn't take a whole lot of thinking to imagine a couple years out and you're looking for some more money to cut because budgets are tight. And people say on Capitol Hill, say, well, we've got this extra $7 billion that we're putting into ARPA-H that's at NIH. So we don't really need to give them their full NIH funding this year, do we? Do you have concerns for things like that?
I do. I mean, I think the larger the NIH budget gets, and what will happen is ARPA-H, if it's included, will be perceived as part of the NIH budget. I think it does become more vulnerable. I think the other thing that's clear is that if the Republicans take control of either the House or the Senate, but particularly the Senate in the midterm elections, there are going to be a series of hearings between Senate leaders. It's likely that Senator Rand Paul from Kentucky will be the chair of the Health, Education, Labor, and Pensions Committee, so the one with jurisdiction over NIH. There'll be hearings about NIH funding and particularly around the pandemic, but then looking at other sort of activities. And I think that's going to really change the relationship between Congress, which has historically been bipartisan when it comes to NIH and to medical research, and the National Institutes of Health, and that creates all sorts of will result in all sorts of unintended consequences, I think, for the research community.
I agree. So I think this is going to have to be one that we put up on the chalkboard for saying we will come back to this for our listeners, because it's something that we're going to need to watch. And as you said, a lot of things are going to be dependent on who has the control of the gavel in the Senate and the House come January 2023.
We should probably move to what the funding legislation, what this funding package means in terms of signals from a regulatory perspective. So what are some of your predictions based on this funding bill?
Well, first and foremost, I think this bill signals that they do indeed on Capitol Hill expect for the public health emergency to expire probably this summer in July. I think that it is very clear that that's exactly what they expect. And I think the administration, even if it does want to extend it, probably is going to find out that there's very little appetite for that. So the extension occurred in January. It'll expire again April 16th. Don't expect, as we've discussed on this show before, don't expect it to end in April, because they have given their word to the states that they would give them at least 60 days notice to prepare for some of the changes that will occur, particularly around Medicaid, actually, and some of the other food programs that are the feds and the states handle together. So somewhere around mid-May, we'll find out if we are indeed going to have that expire in mid-July. And the reason why I think this really indicates that that's going to happen is because there's so much interest in what has happened in telehealth during the public health emergency that a lot of different individuals within healthcare, ASN being one of them, have all been saying you need to be able to provide some transition. You can't have the public health emergency. Well, you can, but we don't recommend it. You have it in one day, and then next day, everything that you've done just absolutely just disappears. And there's been excuse me if I'm trying to remember, it's either 130 or 140 extensions of telehealth payments in particular areas where they have been approved through waivers during this period. So what happened was this bill does include, and it's now law, it does include a 151-day extension of the telehealth waivers past whatever day it is declared. And so if it expires on July 16th, 151 days gets you to the beginning of 2023, which kind of tells you that they really are expecting this to happen this summer. So, and that's something that you and I have talked about, and others at ASN have talked about, and leaders have talked about, which is we're going to need to really be prepared and be very detailed in making sure that the members of ASN and anyone in healthcare can find out just what really does remain and what is happening once we get to that point. So when we get to day one after the public health emergency is allowed to expire, that we're not running around going, can we still bill for this? Can you still bill for this? Do you have to use a modifier for this code? What are you going to do here? Is this allowed? Is this allowed? Are we going to have some reciprocity between states about workforce issues going across state lines? And it does allow originating sites to continue to be much broader than they were pre-pandemic.
Yeah, so it's interesting, as we've crossed the 2-year mark from when the World Health Organization declared COVID-19 a pandemic. We're at a point now where, as you mentioned in the beginning, the large funding package that funded the fiscal year through the end of September did not include any funding for responding to COVID-19. So that's sort of the first point. The second point is that the public health emergency is likely to expire, if you will, by mid-July, and then there'll be this extension that takes us through the end of the year. And so it really puts a lot of pressure, I think, on the healthcare community in general and on the kidney community in particular around, what does the rest of 2022 look like from a perspective of, cases are probably still going to continue, and there's still going to be a lot of stress on the healthcare system. And so in addition to providing this information so everyone understands what is and isn't allowable, particularly for telehealth, what else should we be doing in terms of making sure that the kidney community is supported as we continue to try to address the pandemic?
Well, there's a bunch of things that I think are really important to look at. First of all, we are still in the midst of a really critical time within the dialysis facilities, and there, I'll get to CKD in a minute, but we are really in a very difficult situation. There are still significant workforce shortages. There are still significant supply chain shortages. We've been operating for now a couple of months with a reduced filtration rate for most everyone who's undergoing dialysis in the country. And that does not necessarily change according to when the public health emergency ends or when telehealth continues to. These are things that are going to need to be really negotiated as they have been for the last couple of months with all people provided, with all of those who are providing services really kind of coming together to work out solutions and to keep the patients as healthy as they can in a very difficult and challenging situation. So there's a lot of that that's going to have to continue on throughout 2022. I think you're going to have more discussion also around whether or not we're still debating whether or not 2021 data, particularly quality data for the quality improvement program in the ESRD program, we're still trying to figure out if that's going to be suppressed for 2023, since it's a 2-year lag from that data would affect payments next year. My guess is that CMS will suppress that data. 2021 was just, that data looks as difficult and as challenging as it did in 2020. So that's going to have to be taken into account. And probably next year at this time, we'll be talking about whether the first half of 2022 is going to need to be suppressed. And these have real world impacts on these facilities and these providers. So that's another area that's going to have to be dealt with. Then you're going to have to deal with what the impact of these programs have had on the kidney models. And so, for example, in the kidney models, the voluntary models, there's something called the patient activation measure, the PAM, which is a measure really about patients overcoming issues like depression and other and the assistance they get in receiving their care. From what I hear, most, and the voluntary model started in January 1. From what I hear, no one has been able to start collecting that data. It's a function that they just do not have the power for right at this moment. So even though they're in the models, and they are supposed to be undertaking certain steps to comply with the model, there's some real doubt as to whether we get to doing that before you even get into the third quarter of 2022. So there's a lot of things that are going to need to be put on there. We're also in the process of reaching out, once again, ASN with the National Kidney Foundation, the Renal Healthcare Association, and the American Nephrology Nurses Association. We're reaching out to the White House to discuss many of the issues around supply chain issues and just kind of making kidney patients a priority. Once again, as we see the new COVID-19 response coordinator come into the White House, and that's Dr. Ashish Jha, who most people know very well as a major voice, public health voice. There's really going to be a lot of that, and that's going to include planning for other supply crises as well. But all of our nephrologists, all of our members keep saying we have a way to go, because we've got a lot of immunocompromised patients, both some of whom who have transplants, but also some of whom by virtue of having kidney failure and undergoing dialysis are in that condition. And we can't just turn around and turn the lights off and say, oh, pandemic's over. You guys going home. There's nothing more for you to see. We can't do that. They need help. And a lot of them have not really had the response to the vaccines that would keep them safe.
Yeah, and I should say that Dr. Jha, the new White House COVID-19 response coordinator, was a keynote speaker at the ASN Kidney Week last fall. And so he clearly understands our community. He understands the needs of the patient population. I have every expectation that he'll be a real advocate for us within the administration. As I'm listening to you talk about the effect of the pandemic on the models, the CMMI models, and I think about the recent news that the partnership among Fresenius, Cricket Health, and Interwell, I can't help but wonder if the private sector is passing the federal government in terms of how care delivery is going to be organized for people with kidney diseases, and providing incentives to really for clinicians to try to identify people either at risk for kidney diseases or early stages of kidney diseases, and to slow the progression. I'm just curious if you think that read on the current situation is reasonable.
I think it is, Todd. I think you're spot on. I think we've seen this. We've talked a lot in the last couple of months about the just large increases in the number of people that ASN members take care of in terms of joining Medicare Advantage. I think it's probably fair to say that Medicare has had its hands full, both dealing with the pandemic and dealing with the movement towards greater value-based care within the kidney space as well. And I think that within the private sector, both providers and payers are looking for opportunities to kind of make their mark and expand, and they're not waiting for the government to go ahead and signal what should happen first or what should happen second. And so I think we are looking at a period of real transition in not only payment stuff, but also just innovation into care delivery really coming our way. And I agree with you that I think the announcement by Fresenius and Cricket and Interwell is a significant moment. And I think that probably we will see, in the future, we will see articles and we will see papers that talk about kind of what trend that started. My crystal ball isn't telling me everything these days, but I think you and I both feel confident that it will definitely have a big impact.
Well, thanks, David. Maybe we'll stop there with your crystal ball or your magic, maybe as you shake your magic 8-ball and make a prediction. But I really appreciate your taking the time, and we covered a lot of ground in today's discussion. I really appreciate it.
Thank you, Todd. As always, I enjoy it.